Hi guys. I wanted to talk to you about one of the new skills in OEC 5th edition. It's for an injury that we've known how to treat for a long time, pelvic fractures. For basically ever, we've treated them with spinal board immobilization, maybe not full backboarding, but we tie them down on the board. 5th edition adds a couple of new wrinkles to that, one of which is that considering the mechanism of injury, if the pelvis is injured, then there's good reason to suspect that the spine is too. So anytime we suspect a pelvic fracture, the book says we ought to be doing full spinal immobilization, including a C-collar, the whole 9 yards. The other new wrinkle is that to help stabilize the patient's pelvis, they've added the technique of using a pelvic sling or a pelvic binder. And I'd like to show you what that looks like and how it works. To start with, let's take a look at the structure of the pelvis, which is a big, bony, bowl-like structure. This picture from the book shows some of the common fracture zones, and when the integrity of the pelvis is disrupted, it starts flopping around in there, which is bad. The problem with pelvic injuries, along with the severe pain that they usually cause, is that there are some great hoses of blood vessels running through it, and disruption of any of those can lead to a lot of blood loss and subsequent hypovolemic shock. So this is a true trauma emergency. You need to stabilize the patient and ship them off as gently and quickly as possible. So for assessment, what are we going to look for when we suspect a pelvic injury? Well, for one thing, when the pelvis is disruptive, you might see the feet rotated laterally and other signs that it's not as stable as it should be. You'll probably see a lot of pain, and you'll see, more than likely, hypovolemic shock. How we do the actual physical part of the assessment has changed a little bit. We don't want to disturb the pelvis any more than we have to. So one medial palpation on the iliac crusts, one palpation to the pubic bone, that's all you'll do. Once you know what you're dealing with, you put the sling or sheet, wrap it around the backboard, and get it positioned so that it's going to wrap around the patient's pelvis. Then, with it in place, log roll the patient onto the board just as we usually do. The tricky bit is managing the sling so that the ends of it don't get stuck under the sides of the backboard. What I like to do is stuff the downside of the sling down past the rail that's on the bottom edge of the backboard. That way it doesn't get stuck. Now bring the ends of the sling up, tie them together, compressing the greater trochanters. Tie it with a square knot. The other thing you want to consider is put the sling low on the backboard. That way when you roll the patient onto it, you're rolling the patient low onto the backboard. That way when you do a long axis drag to position them, you only have to drag them once and you're going up pulling on their torso rather than having to ever go down pulling on their legs, which, as you can imagine with a pelvic fracture, is a bad idea. Notice here we've got two patrollers pulling up, one on the sling and one managing the feet. One drag and he's positioned. With the patient positioned on the board, pad under the knees so that they're slightly flexed. That'll help a lot with patient comfort. And then you can proceed to attach them to the board. I prefer to use webbing instead of straps because the webbing is a lot easier to adapt to funny situations like having to avoid the pelvic crust instead of using them to anchor a patient to the board. A good technique for that is to roll up a blanket along the affected side and strap over that. That spreads out the pressure of the straps a lot. And remember, it's a full spinal immobilization, head to toe, head beds, and the whole 9 yards. Finally, although we're usually all about returning patients to anatomical position, you should never do that with a pelvic fracture. Again, those bone ends sawing around in there is really bad. So if the patient's foot is rotated or their knee is flexed, just splint it as it lies. Put them on the board, get them down the hill, and alert EMS because they're probably going to be shocky. That's about all I've got. Thanks for listening. We'll see you on the hill.